Hey group, let's continue to talk about those respiratory cultures and pathogens in Unit 2. One of the most common cultures that you're going to see in the clinical lab is the throat culture. So I want to talk a little bit about how we collect throat cultures because oftentimes that is done by the medical laboratory scientist or technician. So in a throat culture, we can screen for just Strep A. We should have our patients sit in a phlebotomy chair and tilt their head back slightly at about a 45-degree angle and breathe deeply. We should use a tongue depressor, a sterile tongue depressor, to push the tongue down, and the patient should say ah. And when they say ah, this actually prevents them from gagging. What we want to swab is the tonsillar areas and the posterior pharynx back there behind the uvula. The uvula is the little dangly thing at the back of your throat. You want to actually swab both tonsillar surfaces and the back of the pharynx right behind the uvula. Anything that looks red or has white patches or areas that look diseased, that's what you want to go ahead and swab. Now, when we remove that swab from the mouth, we want to remove it without touching the inner sides of the cheeks or the tongue or the teeth, because that's just going to give you more contaminating normal flora when we're trying to look for those beta hemolytic Strep A organisms. Just to kind of review, we're looking for beta hemolytic organisms on blood agar that has either been incubated anaerobically, because that makes the hemolysis really pop, or we want to look at a blood agar that's been incubated aerobically with agar stabs. And those agar stabs actually push the organism down into the anaerobic layer of the media, causing better visualization of hemolysis. Okay, we always want to use a 4-streak method because we do want to pull out those group A Streptococcus organisms, the ones that are beta hemolytic and dry looking. We can also set up a bacitracin disc and an SXT disc onto the media to help screen for Strep A. If we are looking for Strep A, of course, it's going to be sensitive to the bacitracin disc. It's also going to be resistant to the SXT disc, and you can see Group B and Group C streps are a little bit different. Now, Group C and G strep can cause a sore throat. Group B strep really isn't normally found in the respiratory tract, but if you find it there, it usually doesn't cause too many problems for your patient. Remember that Group A strep is PYR positive and esculin negative, and the best way to identify a Streptococcus Group A is by serotyping. That's kind of the gold standard. So here we can review what a Streptococcus Group A or a Streptococcus pyogenes looks like on blood agar medium. They are small, dry colonies with large zones of really popping beta hemolysis. They're going to be sensitive to the bacitracin disc and resistant to SXT. Now, SXT is widely used to differentiate Strep A from Strep C. Remember that Streptococcus pyogenes is catalase negative, and it will serotype with the A latex. There are a number of different rapid antigen kits available to test our patients for Strep A organism. Now, some of these kits all have basically the same principle. These are definitely called the direct ELISA kits, and there are kits made by Immunostics, OSAM, Quidel, and BD Directogen, but pretty much the kits all have about the same principle. Here we are looking for the antigens from the Strep A organism, and if they're present, we can say our patient has Strep A. Now, these kits are only about 75% sensitive, so it's always best to culture in addition to doing the rapid A strep test. Here we have the Immunostics Strep A test kit, which is pretty easy. This is a direct ELISA method where we're looking for a chromatographic immunoassay antibody-specific Strep A is coated on the strep membrane. That is a cellulose acetate membrane. The antigen coding the Strep A organism present is extracted from the organism, and that antigen is going to migrate up the test strip and link with antibody. If you have one line that is positive or one line that's colored, it means it's a negative test. If you have two lines that are colored, it means that it's a positive test. And if you have no colored lines on the test stick, that means the test is invalid. The OSAM kit for Strep A is very similar to the Immunostics kit that we just talked about. Here we have an immunochromographic assay where the rabbit antibodies are specific to Strep A and they're coated on a cellulose acetope membrane. The Strep A antigens, if present, are going to be extracted from the organism and they're going to migrate along the membrane in a liquid suspension. Anti-Strep A capture antibody binds with the antigen and forms a colored line when it links up with the conjugate. A positive test is indicated by 2 colored lines in the test lane. The Queedle inline Strep A antigen kit is a little bit different. It has a similar principle, but this kit uses a lateral flow immunoassay and an inline device for antigen extraction. So basically what we do is we take the throat swab and we mix it with the extraction solution to extract any antigens off the organism. The test chamber contains anti-Strep A antibody, and if Strep A antigen is present, it's going to bind with that antibody and form a pink colored line. Here you can see that the extracted antigen actually goes into a test well, and that well disperses the liquid up into the test lane. In the BD Directogen kit, we have an antibody specific to Strep A that coats the test line region of a test strip. The throat swab organisms are extracted, just very similar to the other kits we were talking about, and they're allowed to coat these particles. The sample migrates up the test membrane and reacts with antibody of the membrane, where a red line develops in combination with antigen-antibody complexes. So it's very similar to the other 3 test kits that we were talking about. And basically, I just wanted to show you here, there are a number of different Strep A detection test kits out there on the market. Let's talk a little bit about the structure of beta hemolytic Streptococcus. For one thing, it has a multi-layer cellular structure that contributes to its virulence. So in other words, there's many antigenic layers, which contributes to its high virulence. In fact, if you get sick, you will only become immune to one layer, so you can still get ill from other strains with different layers. The outer capsule of the organism protects it from phagocytosis. Specifically, those are M protein antigens. The cell wall is composed of these M protein carbohydrates and mucopeptide layers, usually on the capsule. Streptococcus Group A also has extracellular products that contribute greatly to its virulence. Some of those extracellular products would be streptolysins, erythrogenic toxins, streptokinase, streptodornase, and things like that. Here we can look a little bit closer at the cell membrane and the capsule of the Streptococcus Group A organism. Okay, it has a capsule that prevents phagocytosis, and then there are extracellular substances like streptolysins, which contributes to cellular lysin. Then we have NADase, which destroys leukocytes, hyaluronidase, which destroys connective tissue, streptokinase, which prevents blood clotting, and streptodornases, which breaks down exudate. We also have other extracellular substances like streptolysin and pyrogenic exotoxins. Okay, there is a carbohydrate layer that you can see indicated by the area with the diagonal lines. This carbohydrate layer actually just determines the serological group for beta streps. Let's talk about Streptococcal Group A pharyngitis, which is just basically another way of saying strep throat. Now, about 60% of the time, strep throat is caused from a viral organism, and about 40% of the time, strep throat is caused from a bacterial organism, and a lot of times that is going to be Strep A. Strep pyogenes is the most common infection of the upper respiratory tract infection when it comes to a bacterial source. Okay, that organism colonizes the pharynx and starts to multiply on the pharynx and the tonsils to produce its toxins. Okay, remember the pharynx is the back of the throat above the epiglottis, or the oral pharynx is what it's also referred to. The incubation period from the time you get sick or from the time you are in contact with somebody with Strep A is about 2 to 4 days. Some symptoms would be things like fever, malaise, headache, chills, sore throat, painful swallowing, swelling, pus covering the tonsils, and swollen lymph nodes. People that have strep throat are very, very sick. Oftentimes you'll see white spots on the tonsils. The tongue can be grayish or furry looking. The uvula can be swollen, and the whole inside of the mouth can actually be red. Now, keep in mind, Streptococcus Group A can actually go from the throat and invade the sinuses, the middle ear, the mastoid, or it can lead to rheumatic fever or bacterial glomerulonephritis if it's not treated adequately in the beginning. Complications from an inadequately treated case of Strep A pharyngitis can lead to things like acute rheumatic fever and acute glomerulonephritis. In acute rheumatic fever, the toxins from Strep A actually affect the heart valves. Some symptoms of acute rheumatic fever would be fever, increased sed rate, inflammation of the heart muscle and valve damage, joint pain, and twitching of the facial muscles. In acute glomerulonephritis, we have immune complexes that form in the kidney and actually destroy the kidney. Here in acute glomerulonephritis, you're going to see edema around the eyes and ankles, or fluid retention, reduced urine output, a smoky red colored urine that's going to be positive macroscopically for blood and protein, and then microscopically the urine is going to show you red cells and red cell casts, and you may also see white cells in the sample as well. So rheumatic fever and acute glomerulonephritis are probably the two most serious complications from an inadequately treated case of Group A strep. But there's also other diseases that can be caused by Strep A, including meningitis, otitis, sinusitis, tonsillitis, and pharyngitis. That's kind of what you hear about when you hear about strep throat. Pneumonia, endocarditis, impetigo, scarlet fever, myositis, which is basically inflammation of the muscle tissues, and fasciitis, which is inflammation of the fascia or the membranes that supports the muscles. Now, it's not just Strep A that causes upper respiratory tract infections. There are other organisms that can cause respiratory tract infections as well, including Haemophilus influenza type B that can cause epiglottitis. We can have otitis media and sinusitis, and those are caused by Streptococcus pneumoniae, Moraxella catarrhalis, and Haemophilus influenza. And then you can also have laryngitis, and that is often caused by Mycoplasma pneumoniae, which we're going to talk about in a later unit. Let's talk about the samples associated with lower respiratory tract infections. So some of the samples that we can collect from the lower respiratory tract would be things like sputum, bronchoscopy specimens, tracheostomy or endotracheal aspirates, transtracheal aspirations, lung aspirates, and lung biopsies. Now, keep in mind, sputums are not acceptable for anaerobic culture because the sample comes up through the mouth and picks up normal anaerobic flora. The only ones that are actually good for anaerobic culture would be lung aspirates and lung biopsies, and also transtracheal aspirations. Okay. In a transtracheal aspiration, this is a needle puncture that actually goes right through the ligaments and into the trachea. What is collected is a bronchwash. There's a lot of commensal flora or normal flora of the respiratory tract, and a lot of that comes from the upper respiratory tract. So some of the normal flora can be things like alpha and gamma strep. Usually I'm not talking about strep pneumo or enterococcus. I'm just talking about your run-of-the-mill alpha and gamma streps. Beta hemolytic streps can be totally normal as long as they're not strep A, C, or G. Coag-negative staphylococcus, diphtheroids, which are gram-positive rods, Haemophilus parainfluenza, and certain Neisseria species. These can all be completely normal upper respiratory flora. Now, in addition to that normal flora, if you have a few colonies of an enteric or a few colonies of a non-fermenter, maybe a colony or two of Staph aureus, maybe a colony or two of Strep pneumo, Moraxella, and Haemophilus and yeast, if you just have a few of those things in the upper respiratory tract, as long as it's there with a bunch of normal flora, those things may actually be overlooked or probably are not pathogens. Okay? Now, if we have yeast collected from a respiratory sample, it's really up to the doctor to decide if it's an opportunist or if it's colonization. Yeast is a common pathogen in people that are being mechanically ventilated. And there's a picture of yeast in a gram stain, and you can see that they are purple. They technically do not have a cell wall that is the same as gram-positive organisms, but they still are able to retain the crystal violet. Here we have a nice list of pathogens of the lower respiratory tract. Any virus, Bordetella pertussis, Corynebacterium diphtheriae, Legionella, Mycobacterium, Strep Pyogenes, enterics and non-fermenters, and Mycoplasma pneumoniae. Remember, any amount of Strep A, even if it's just 1 or 2 colonies, is considered pathogenic. Now, pathogens that we can see in moderate amounts, or when it's with normal flora, is going to be Staph aureus, Strep pneumoniae, Moraxella catarrhalis, Haemophilus influenza, and yeast. And what that's saying is if you have a few of those colonies collected in the lower respiratory tract and there's no normal flora, those would be considered pathogens. Now, people that have lower respiratory tract infections, they usually get that in a variety of ways. They can have a respiratory pathogen that's been inhaled, or they could have what's known as aspiration pneumonia, or these organisms could have come from the bloodstream. Organisms considered normal flora of the upper respiratory tract may actually be opportunistic pathogens of the lower respiratory tract. Out of all the respiratory tract diseases, pneumonia is probably the most serious. And there's many different types of pneumonia. They're characterized in a number of different ways. One is called atypical pneumonia, which is a mild pneumonia with minimal sputum produced. It's also known as primary atypical pneumonia. It's not caused following another disease, but it is often caused by a virus, mycoplasma, rickettsia, that's the organism that causes Q fever, chlamydia, or this is also known as walking pneumonia. Then there's acute pneumonia that is usually community acquired from an opportunistic upper respiratory organism. And then there's aspiration pneumonia, where the flora that is in the upper respiratory is sucked into the lungs where they become pathogens. And this may be a mix of aerobes and anaerobes as well. This is usually due to incomplete glottic closure and suppressed cough reflex. So you can see this in older people when they have a suppressed cough reflex. When you're in the hospital, there's always a risk of developing what's known as nosocomial pneumonia, which is a hospital-acquired pneumonia. Oftentimes, these types of illnesses are caused by enterics such as Klebsiella, Enterobacter, E. coli, or Serratia. Any enteric could really cause a nosocomial pneumonia. Okay? It is pretty typical for these types of organisms to colonize the throats of hospitalized patients. Some other risk factors would include increased colonization of the upper respiratory tract in elderly patients, patients with more severe illnesses, patients previously treated with antibiotics, and patients with increased gastric pH. These people are more prone to aspiration. So in other words, bugs from the gastrointestinal tract aren't killed and they can be aspirated. Respiratory opportunists would include any organism that has the ability to cause you sickness when your immune system is suppressed. Opportunistic infections can happen to immunosuppressed patients or those with defects in cellular or humoral immunity. Some opportunistic respiratory pathogens would be herpes virus, cytomegalovirus, Cryptococcus neoformans, which is a yeast. It's associated with pigeon poop. That is usually seen in cerebral spinal fluid, and if you have Cryptococcus in the spinal fluid, you have a life expectancy of about only 2 years. Aspergillus is a mold that causes a disease known as aspergillosis. We have Histoplasm capsulatum, which is a dimorphic fungal organism that causes lung disease. And then we have Pneumocystis jirovecii. It used to be known as Carinii. This is a yeast formerly classified as a protozoan that is often seen in AIDS patients. I'm sure you've heard of Pneumocystis pneumoniae or Pneumocystis pneumonia. That is usually not seen in the general populace. It's usually only seen in AIDS patients. There's quite a big difference between a bacterial pneumonia and a viral pneumonia. As you can see with the bacterial pneumonia, it comes on suddenly and with a bang. Usually you get one big chill and then you end up getting a fever. Usually when you have a bacterial case of pneumonia, you're coughing up bloody purulent sputum. You can develop pleurisy, and the white cell count is usually greater than 15,000. In the case of viral pneumonia, it comes on kind of gradually, and you may always kind of just feel chilly all over. You may have a fever, but it's not as high as what you would see in a bacterial pneumonia. Usually the cough is non-productive, and pleurisy develops very rarely, and the white cell count is going to be quite a bit lower in cases of viral pneumonia. When we get our respiratory samples in the laboratory, there's quite a few direct examinations that we can do that's going to be helpful for us identifying the pathogens. One thing that we can do is a direct gram stain. Usually this is on lower respiratory samples like sputums. We can do acid-fast stains where we're looking for things like Mycobacterium tuberculosis. We can do wet preps where we're looking for yeast or fungal elements, not broken up with touch preps. Touch preps usually don't break up the fungal elements, so that's one way to find fungal elements. And if you look at those three pictures there, we have a gram stain on the top where you can see Streptococcus pneumoniae, gram-positive cocci in lancet shapes in pairs. On the bottom left, we can see acid-fast organisms in the Kenyon's carbofusion acid-fast stain. The pink organisms are those organisms that have a very high waxy layer in their cell wall, so they don't gram stain well, but they do acid-fast stain. And then over on the right, we have an example of phase microscopy where we're looking at fungal elements. Now, anytime we are culturing a sputum, we want to make sure that we have a good, deep specimen of sputum and not just spit or saliva. And so we have to do the gram stain on the sputum to determine if it's acceptable for culture. Okay? The sample has to be stained and then viewed on 10x before the culture is actually set. We are looking for a sample that has greater than 25 white cells and less than 25 epithelial cells per low power field. If you see an average of 25 white cells or greater and less than 25 squamous epithelial cells, it means that the sample is good for culture. It means that we have a deep sputum sample and not just spit or saliva. Now, whenever you're screening sputum samples for culture, we want to make sure we look at a minimum of 10 lower power fields and take the average amount of squamous epithelial cells and the average amount of white cells per field. Unacceptable samples will still get a gram stain, they're just not going to get cultured. There are certain plates that we're going to set up for lower respiratory tract samples, and usually I'm talking about sputums. We're going to set up a blood auger with CO2. That's going to pick up your strep pneumos. We're going to set up a blood auger that's anaerobic. That's going to pick up your strep A. We're going to set up an aerobic, or either that or an aerobic blood auger plate with auger cuts. We're going to set up a chocolate auger with CO2. That's going to pick up your Haemophilus influenza. And then finally, we're going to set up a MAC, and your MAC is going to pick up your enterics and some of the non-fermenters. Now remember, anaerobic cultures can only be done on transtracheal aspirations, lung aspirates, and biopsies. A lot of times those are actually classified as wound cultures because of that reason. Some other lower respiratory tract samples would be transtracheal aspirates, bronchial alveolar lavages, lung aspirates, and lung biopsies. Just keep in mind the trachea, the bronchi, the lungs are normally sterile. You have to remember, though, that when these specimens are collected, they do pass through the upper respiratory tract, and that causes it to pick up normal respiratory flora. Significant pathogens are those organisms that are predominant, so consider the type of organism growing and the immune status of the patient. So if we have a whole ton of Staphylococcus aureus and hardly any normal flora, then that Staph aureus would be considered opportunistic pathogen. Let's take a look at some plate and growth correlations on the next slide. So if you have organisms growing on your plate, you can kind of quantitate that with how bad the infection is. So for example, if you have Staph aureus that's only growing in your first streak, we could report that out as rare or few. If we have organisms that are growing into the third and fourth streak, we could say that the organism count is many. So we are looking at all amounts of different organisms, and then we have to ask ourselves, is there a lot of normal flora or is there very little normal flora? So something like Staph aureus can be a pathogen if there's very little normal flora, but on the other hand, if there's only rare to few Staph aureus and there's a ton of normal flora, then it's most likely insignificant. Let's go ahead and talk about some other respiratory pathogens that are a little bit less common. So let's start with Bordetella pertussis in the next slide. Bordetella pertussis causes whooping cough, and the whooping cough was named after the whoop sound that people make trying to catch their breath after a long period of coughing. Okay, there are over 350,000 deaths per year because of Bordetella pertussis. Humans are the only host. Some symptoms of Bordetella pertussis would be fever, vomiting, cyanosis, that means they're turning blue, and a pretty severe cough. There's a couple of virulence factors associated with Bordetella pertussis, including membrane proteins, which help the organism attach to the host, and the pertussis toxin, which actually interferes with the host proteins. Okay? So you can see in that image there we have Bordetella pertussis on charcoal agar, and it looks like little mercury drops. At the hospital, a nasopharyngeal swab is collected at the bedside and is immediately placed into a Reagan-Low deep. That black media is called Reagan-Low, and they're going to collect mini tip swabs from the nasopharyngeal area, and they're going to actually stick it into a test tube that has Reagan-Low media in it. After a couple days, that Reagan-Low, those mini tips are taken out of the Reagan-Low media and put on plates. Okay. Sometimes people will do PCR to help diagnose Bordetella pertussis, and other times they're going to be doing DFA, which is direct fluorescent antibody. Corynebacteria diphtheriae is one of the few significant diphtheroids. Okay, it is common in developing countries like South America and Europe. The disease is usually characterized by a low-grade fever, pharyngitis, and a blocked airway. It is uncommon in the U.S. because we get vaccinated for it. There's actually 3 doses between the time you're 6 weeks old and 12 months old. Okay. Corynebacterium diphtheriae is very virulent because of the diphtheria toxin. The toxin actually affects cellular cytoplasm of the host, resulting in dead necrotic tissue of the throat, heart, and liver. If there is too much necrotic tissue of the heart and liver, this does result in death. Okay? Now, kids are often more susceptible to diphtheria because adults fail to get their booster shots, and that usually results in outbreaks of diphtheria. Diphtheria is transmitted by aerosols, and the media we want to culture it on is cysteine tellurite blood agar or modified Tinsdale agar or Loeffler's media. On modified Tinsdale agar, you're going to see that Corynebacterium diphtheriae would be brown or black colonies surrounded by a brown halo, and you can see that on the bottom left image. Okay. Corynebacterium diphtheria does require an irregular aerobic incubation at 35 degrees Celsius, and it is a gram-positive rod. Mycoplasmosis pneumoniae is an opportunistic respiratory pathogen that causes about 10 to 30% of all cases of pneumonia. It is difficult to culture, and it may be diagnosed serologically by looking at IgM or IgG antibody levels. It is often treated with tetracycline or erythromycin. If we were trying to grow it, we would try to grow it on PPLO media. PPLO stands for pleural pneumonia-like organism, and it was first named because of mycoplasm that was discovered in cows that have pleural pneumoniae. These are considered soft-skinned organisms and are the smallest of the free living organisms. They're very, very small. They're not going to gram stain because they have weak, thin cell walls. You can do what's known as a Dean stain, D-I-E-N-E-S, Dean stain, and you would see what looks like a fried egg appearance, and you can see that on the image on the right. Legionella or Legionella pneumophilia accounts for about 2 to 15% of community-acquired pneumoniae. There are about 8,000 to 18,000 hospitalizations every year in the United States. Now, Legionella species causes Legionnaire's disease and Pontiac fever. It is technically a gram-negative rod, but it doesn't stain easily with gram stain. Giemsa and Diff Quick stains work best. If you do try to gram stain, it is best to leave your safranin on for about 10 minutes. Now, Legionella is a fastidious organism and does require L-cysteine and iron salts for growth. So the media we want to culture it on is called charcoal yeast extract agar, or BCYE, buffered charcoal yeast extract agar. It's the same media that we use to grow Francisella as well. In about 2 to 4 days, your Legionella is going to have a ground glass appearance, and it is slow to culture. Possibly the best ways to diagnose it is by doing a direct fluorescent antibody test or to do a urine antigen test. And there's one type of urine antigen test out called the Binax urine antigen test. It is 97.1% sensitive for Legionella antigen, but it does need to be confirmed with culture. So Legionnaire's disease is quite a bit more serious than Pontiac fever. When you have Pontiac fever, it just basically feels like you have the flu or influenza. In Legionnaire's disease, there is a pretty high mortality rate of about 15 to 30%. People that have Legionnaire's disease have fever, chills, chest pain, cough, excessive sputum, and diarrhea. That's kind of an odd symptom, but that seems to be typical. People with Legionnaire's disease have pneumonia with lung abscesses. They can succumb to renal and liver failure, and they can also be delirious or disoriented. People that have Pontiac fever, it is not deadly. They have kind of flu-like symptoms, including fever, chills, and cough. They generally don't develop pneumonia or lung abscesses. Usually their liver and kidneys aren't affected. There's usually no GI involvement and no nervous system involvement. Like I said, when a person has Pontiac fever, it just feels like they have a bad case of the flu. So here's kind of a nice list of the common pathogens and how to identify them. So Staphylococcus aureus, if you recall from Micro 1, is a moderate to large white or yellow beta hemolytic butyrus colony. Sometimes they can be gamma hemolytic as well. We obviously identify Staphylococcus aureus by catalase and coag. Strep pneumo, you're looking for small alpha hemolytic divots or penny edge colonies, or you could find a mucoid strain of strep pneumo. We identify strep pneumo with a catalase and an optogen test or biosolubility. Strep A or Strep pyogenes is a small, dry, beta hemolytic colony that can be screened for using bacitracin and SXT, but the best way to identify Strep A is by serotyping. Moraxella catarrhalis, you're usually going to notice that right away because it has a pinkish hue. It can be whiter, it's usually dry, and you can push it around the media like a hockey puck. The best way to identify Moraxella catarrhalis is with a catalase and an oxidase test and a butyrate esterase test. Haemophilus influenza grows greenish or tannish green on chocolate agar. Remember, Haemophilus influenza does not grow on blood agar. It tends to have kind of a mousy smell, and the best way to identify Haemophilus influenza is by setting up the XMV test. It will require both the XMV. Enterics are usually large and damp, shades of gray on blood agar. They grow on selective and differential media, including MacConkey agar. Enterics can be easily identified by setting up API, Vitek, Microscan, and tests like that. Non-fermenters, they usually give themselves away because they are different colors like yellow, green, or purple. And one thing that is usually pretty apparent with most non-fermenters is that they're oxidase positive. Not all non-fermenters are oxidase positive, but Pseudomonas aeruginosa, which is the most common non-fermenter, is oxidase positive. So the reason why in this slide I've described all of their macroscopic appearances is because when you are dealing with respiratory pathogens, you have to notice these morphologies among a sea of normal flora. You kind of have to pick out the pathogens from the normal flora. And then finally, the last slide here is just a summary of everything I said in the previous slide. And these are ways that you can identify respiratory pathogens. So Staph aureus, catalase positive, coag positive. Strep pneumo, catalase negative, optogen sensitive, or biosolubility positive. Moraxella catarrhalis, oxidase positive, butyrate positive, or you can identify it with Bacticard, even though that's a little bit more expensive. And for Bacticard, it's going to be IB positive. Haemophilus influenza is going to require both the X and V blood factors. Enteric gram-negative rods, you can set up API, Microscan, or Vitek. Non-fermenters, usually those are identified through API, or Vitek can sometimes identify them. A lot of times they're oxidase positive. Usually they're OF glucoses. They can be oxidizers or non-oxidizers. Strep pneumo, bacitracin, SXT, and serotyping. And yeast, we can do a wet prep and then a germ tube. And a germ tube is a confirmatory test for a yeast known as Candida albicans.